Hello and welcome to our new topic. Another interesting yet difficult topic for many learners, that is drugs used in cardiac arrhythmias. The cardiac arrhythmia comprises of a group of disorders characterized by an elevated or reduced heart rate, more or less than the normal range. The normal range is 60 to 100 beats per minute. A heart rate more than 100 beats per minute is called as the tachyarrhythmia, while a heart rate less than 60 beats per minute is called as the bradyarrhythmia. Today's topic is about a group of drugs which are used to control life-threatening tachyarrhythmias of heart. For bradyarrhythmias, many conditions would require implantation of a pacemaker, which is an electronic device to stimulate the heart and helps to keep the heart rate within normal range. There are certain drugs which can be used to increase the heart rate if it falls below the normal range, such as atropine and epinephrine, but that is not part of our lecture. Here we would focus only on tachyarrhythmias. Since some of these drugs are also used in other disorders, and have already been discussed separately, we will focus here on those drugs which are not discussed anywhere else, to avoid duplication of the content. So, let's start. By the end of this session, you should be able to describe how myocardial ion channels work and how they generate the cardiac action potential. Classify antiarrhythmic drugs based on their mode and site of action. Explain the pharmacokinetic properties, mechanisms of action, adverse effects, and clinical uses of these drugs. Finally, discuss useful combinations of drugs in managing different types of tachyarrhythmias. Keep in mind that antiarrhythmics are powerful agents. They can both treat and provoke arrhythmias, so a deep understanding of their electrophysiological actions is crucial for safe use. Let's begin by recalling that the myocardium, the muscular tissue of the heart, is an excitable membrane just like other electrically active tissues in the body. This membrane contains a variety of ion channels that regulate the influx and efflux of charged particles, particularly sodium, potassium, and calcium ions. These ions are the key players behind the generation and propagation of the cardiac action potential. When sodium ions rush into the cell, the membrane potential becomes less negative, initiating depolarization. Potassium, on the other hand, moves out of the cell, driving repolarization. Calcium channels also play a critical role, especially in maintaining the duration of the cardiac action potential. These channels open more slowly than sodium channels, which gives cardiac muscle its distinctive electrical behavior. If we were to plot the cardiac action potential, it would start at around -85 millivolts. As sodium floods in, the graph shoots upward, the upstroke or phase 0, reaching as high as +30 millivolts. When sodium entry stops, potassium begins to exit the cell, trying to restore the negative potential. However, during this time, calcium channels open and allow calcium to enter, balancing the movement of positive ions and producing a plateau phase, phase 2, a unique feature of cardiac muscle. After the plateau, calcium channels close, potassium efflux dominates, and the membrane potential returns toward the resting level. This is phase 3, repolarization. Sometimes, the potential becomes even more negative than normal. This is called hyperpolarization or phase 4. In pacemaker tissues like the SA node, phase 4 gradually drifts upward due to special ion channels, bringing the membrane to the threshold potential and triggering the next depolarization. Behind all this, the sodium-potassium ATPase pump maintains ion gradients by pumping 3 sodium ions out and 2 potassium ions in, while other transporters, like the sodium-calcium antiporter, fine-tune calcium levels. This is another interesting slide showing which ions move inward or outward during various phases of cardiac action potential, supplementing the information in the previous slide. The red-green text shown on the right denotes the gene and protein underlying those ion channels. Now, it's important to realize that not all cardiac cells behave the same way. Ventricular and Purkinje fibers show the typical 5-phase action potential, whereas SA and AV nodal cells, The pacemakers lack the distinct plateau and rely mainly on calcium currents for depolarization instead of sodium. Their action potential has only three main phases: an upstroke, phase 0, repolarization, phase 3, and a spontaneous diastolic depolarization, phase 4. The SA node is the primary pacemaker, while the AV node takes over if the SA node fails. Antiarrhythmic drugs are classified according to the ion channels or receptors they block. Class 1 sodium channel blockers. Subdivided into 1A, quinidine, procainamide, disopyramide 1B, lidocaine, mexiletine, phenytoin 1C, flecainide, encainide, propafenone, morphazine. These differ in how they bind to sodium channels, whether in the resting, activated, or inactivated states, as discussed in more detail in the next slide. Class 2 beta-adrenoceptor blockers. Examples: propranolol, atenolol, metoprolol, esmolol. They reduce sympathetic drive, slowing SAW and AV nodal conduction. Class 3 potassium channel blockers. Examples: amiodarone, ibutylide, dofetilide, sotalol. Sotalol, although a beta blocker, is classified here due to its dominant potassium blocking effect. Class 4 calcium channel blockers. Examples: verapamil, diltiazem. Unlike dihydropyridines, such as nifedipine, which act on vascular smooth muscle, these target cardiac calcium channels and slow nodal conduction. Class 5 miscellaneous agents. Examples: adenosine, digoxin, magnesium sulfate, ivabradine, ranolazine. Each has a unique mechanism outside the traditional channel blockade. Please note that the drug names shown in bold font are the ones commonly used. Sodium channels are present in myocardial cells and are responsible for the fast upstroke of phase 0. These channels are composed of protein subunits and have an external gate and an internal gate. These sodium channels exist in three states: resting, activated, and inactivated. During resting state, the external gate is closed and internal is open. When activated, the external gate also opens up, forming a tunnel-like passage for sodium ions. Soon, the activated channel will be inactivated by closing the internal gate. Shortly thereafter, the external gate would close and internal would open to regain the resting state. Class 1B drugs act on activated channels, showing use dependence. Class 1A act on active and inactivated channels. Class 1C drugs bind in all three states, producing the most marked slowing of conduction. As a result, Class 1A drugs moderately decrease depolarization rate, Class 1B minimally affect it, and Class 1C markedly depress it. Class 3 drugs prolong repolarization, and hence the refractory period, while Class 4 shorten recovery by removing the plateau. Now, think about where these drugs act. A drug acting during phase 0, clearly a sodium channel blocker, class 1. A drug that flattens or slows phase 4, a beta blocker, class 2, since it reduces the slope of spontaneous depolarization. A drug that prolongs phase 3, a potassium channel blocker, class 3. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!